Hi, good afternoon. Thanks so much for joining our abstract plenary. I am Cindy Brock with the Agency for Healthcare Research and Quality, and I'm so pleased to be with you today for our, I think Michael said it was the 13th year, and I've been to every conference, so I should know, HARC meeting. We have four terrific presentations for you this afternoon. I do recognize that there are no breaks between the sessions, so I hope you grab something to eat, stand up and stretch. We love it all, and want to remind you to please chat in questions, comments, resources. In this virtual environment, we really want to encourage as much interactivity as possible, and Zoom can be our friend because you don't have to interrupt. You can just, put things in, thoughts, reactions, as well as your questions and resources. So without further ado, those of you who know me know that I'm a very informal person. So no disrespect intended to our presenters when I call them by their first names. We're want to refer you to the speakers page of the website for their full and illustrious bios. But we're just going to jump in with just the briefest of introductions. So we're going to start today with Jessica DeFrank, who is a health behavior research scientist with the Center for Communication Science at RTI International.
Michael LaCroix.
I think.
What do you say? Am I in trouble?
No, you're just not muted. You're not supposed to be talking now. So Jessica is sharing her screen. I'm going to mute myself and let her take the stage.
All right, everybody, thank you so much. In the interest of time, I'm going to go through the introduction part quickly, but I'm Jessica DeFrank. I'm with the RTI Center for Communication Science. And today I'm going to talk a little bit about how clinicians, how prescribers who prescribe prescription drugs understand data displays that present clinical trial information in prescription drug promotion. And we attempted to understand this through doing a systematic review of the literature. So before I get into this, I want to acknowledge and thank our funder, the FDA Center for Drug Evaluation Research, the Office of Prescription Drug Promotion, OPDP. And I also want to acknowledge our team from RTI International and FDA. Okay. Forwarding to the next slide here, hold tight. My screen is freezing, so let me go back here. Apologies. So as I had mentioned, the purpose of this research was to understand how clinicians perceive, react to, and use data that's presented about clinical trials. So here are some examples of what clinicians might see in prescription drug promotion. So these are example ads for different drugs, and you can see that there are some complex data displays embedded in these ads. So it's not clear how prescribers understand this information, if they've been trained to understand it, if they understand what they're seeing, what these results are telling them, and how they use this information. So we started with a review of the literature, and we found that there's very little out there. There's a lot about how patients understand data displays, but very little bit about how prescribers understand these types of data displays. So we first sought to conduct a systematic review of the literature on this topic. So we used standard systematic review approaches. We searched for literature through several different databases. We conducted a hand search using PubMed and Google Scholar. And we also identified, of course, our inclusion and exclusion criteria for these types of studies. So again, we were interested in prescribers, those who are prescribing drugs, including physicians, nurse practitioners, et cetera. And our outcomes of interest were those that were essentially self-reported. So how do they perceive or understand information? What are their perceptions, preferences of this information, and how do they use it for decision making? We used a rigorous systematic review methodology that included dual review of titles and abstracts, full text review of articles, and a standard data abstraction form. One nice thing about this review is we used something called the Distiller Systematic Review software that helped streamline the systematic review process, and which was a much more valuable a tool, I think, than using some of the software that we've used before. So on to the results. We started with 1,000 different titles and abstracts and whittled that down to 15 included studies in our review that met our inclusion and exclusion criteria. So let me spend the majority of our time today talking a little bit about what we found in this literature. So of these 15 articles that included prescribers, most of them, or 87% of these articles, surveyed physicians, and there were fewer articles that surveyed other healthcare providers that would prescribe prescription drugs, including nurse practitioners and physician's assistants. So that was an immediate gap we found in the literature. And then we looked at the type of data that was found in these, more complex data displays, as you saw earlier in this presentation. So the type of data really varied. Some of these outcomes looked at, risk of disease or risk of side effects. Others looked at health-related quality of life, mortality, survival, etc. So there was really a big array of different types of data in these displays. Of interest, I found that only one type of study surveyed providers about meta-analysis outcomes. So these are those forest plots. For those of you familiar with meta-analyses, these are the forest plots that are used to summarize a lot of different studies on a single topic. So there was only one study that surveyed clinicians on how they understood those types of outcomes. We also wanted to know what types of comparisons were being done in these types of studies. So for example, a lot of these studies compared to two different types of data displays. So was it a bar chart versus a line graph? Was it a visual or a data display versus a non-visual, which may have just been text or a narrative? So there are many different types of comparisons in these studies. And finally, of note, we looked at the disease context. Many of these studies were done in the context of cancer, but then there were also just various other types of medical context evaluated in these studies as well. And then finally, we looked at the different types of outcomes that were included in these studies with clinicians. So as you can see here, the most commonly studied outcome was objective comprehension. So this was basically a test of how accurately they understood the data that was shown in these displays. So objective comprehension was kind of the #1 outcome. Many of these studies compared objective comprehension with also subjective comprehension. So is this how did they perceive that they understood it? How easy was this to understand? Other outcomes of interest were preference. So did they prefer one type of display to another one? And then hypothetical decision making. So if they were to prescribe a drug, given what they are seeing, what would they be likely to do? So I'll quickly go over what we thought were our key findings from this systematic review. Again, there were only 15 studies, so it's really hard to have a robust conclusion, but here are the kind of the trends that we saw. In studies that assessed objective comprehension of these complex data displays, these scores, the accuracy scores, were actually quite low. So clinicians were scoring in the low to moderate range for understanding this information. Another interesting finding that in studies that assess subjective comprehension, the clinicians perceive that that the information was clear or easy to understand. So there was this disconnect between objective and subjective comprehension of the information in these complex data displays. Another interesting finding was that data display formats that were preferred did not always correlate to better comprehension. So for example, clinicians tend to prefer just a simple data table. That was the preferred format, but those did not necessarily lead to better comprehension. And in fact, other formats like an icon array led to better comprehension, but those were often the least preferred format. And then a lot of most of the decision-making studied relied on hypothetical scenarios. In fact, none of them looked at actual decision-making outcomes, which was another key gap in the literature. And as I alluded to before, a lot of the literature out there included physicians, but few included non-physicians who prescribe medication. And we already talked about these studies relying on hypothetical scenarios instead of real decision-making and outcomes. And another gap that we found was that there was really no evidence out there on how well clinicians understand meta-analyses displays. And I think this is warrants future research, because as we know, meta-analyses are a really good way to compile a lot of information into one display. And it's a tool that's often used in decision-making in clinical trials. So I think there's a room for more study around how clinicians understand meta-analyses. And then another gap we found in the literature is in all of these studies, we didn't really see much attention paid to how clinicians understand statistical uncertainty or statistical variance. And by that, I mean anything from error bars and confidence intervals to information on conflicting information. If, study A shows one outcome, but study B shows another outcome. So I think there's some room for understanding statistical uncertainty in this body of literature. So to kind of wrap things up, as I said, we identified a very small number of studies in the systematic review, only 15, relative to the likely thousands of articles published on medical therapeutics during the same time frame. So again, we know a lot about clinical trials and how those perform, but a little bit about how clinicians understand the information in these clinical trials. And finally, there's a very large body of literature out there on best practices for developing data displays for patients, but not a lot about how to convey the same information to prescribers. So we don't know if that literature can be applied. We suspect that most of it can, but maybe not. So we need to think about how to best display information for clinicians when it comes to clinical trials. And so I said best practices are needed for developing information and data displays for this this group. And with that, I see that Cindy has popped up, and I think I'm out of time. But thank you for giving us some time to
go ahead and make your last two. You can go through your last two.
Okay, good. And finally, we do think there are some opportunity here to better educate and train clinicians on how to understand these complex data displays. So not only are best practices needed for developing these displays, but education on the other side to better guide clinicians on how to interpret and use these data displays. And I'll include my references here at the end of my presentation. And if you'd like to learn more, here's my contact information. So thank you very much.
So thank you, Jessica. This presentation underscores one of the fundamentals of health literacy for me, which is health literacy is for everybody. It's not just patients or the public or consumers. It's our highly educated workforce. And we can all have difficulty understanding information and the importance of universal precautions and making sure that people can understand, your audience, your targeted audience can understand information the first time they read it. So loved illustrating those points. We have several questions here. So I'm going to start with one that was also top of my mind, which is, why do you think there was discordance between preference and efficacy? What they liked wasn't always what helped them understand the easiest.
Yeah, that's a really good question. I would love to explore that a little more fully. I think clinicians they want just to see the data, the tables, right? I think they just would rather see those not raw numbers, but just the numbers rather than some sort of visual presentation of that. But at the same time, the evidence showed that that is not always the best way to convey complex information. So why, I'm not sure why that happened, but that's definitely worth future exploration.
Okay. Another question is, what were the top reasons for excluding literature from the review?
Excluding, let's see, I have to think back on that. But so our review was focused only on complex data displays as they appear in prescription drug promotional material, because this was a focus of our funder. So that would have been one of the larger exclusion criteria. So there could have been other types of studies out there that looked outside of prescription drugs. So maybe it looked at vaccine literature or other type of clinical trial settings, but we just wanted to focus on prescription drugs.
And I'm going to we have time for one last question, so I'm going to defer the other questions we received till the end. We may have some then. And thank you everybody for chatting in your questions. So were there any specific measures of objective and/or subjective comprehension that stood out?
That's one thing I found is that these measures were so varied. It really depended on the actual study itself. And so they were very specific to that one study. So nothing really stood out for me. It was basically, they felt like a quiz, right? If they were understanding that information. I do know that there tended to be a lot of errors when it came to understanding absolute versus relative risk, and that has been studied before. So what's the difference between those two? But yeah, that they were varied across studies. Yeah. So, no.
Always the challenge of meta-analyses.
Right.
Thank you, Jessica. We'll bring you back at the end. And I am now going to introduce our next speaker. Samantha Radakonda is a first-year medical student at Tulane University School of Medicine. So Samantha, you should unmute. And I see you've already got your presentation up, so roll it.
Hi, everyone. I'm Samantha Radakonda. I'm a first-year medical student at Tulane University School of Medicine, and I worked in the Family Medicine Department at University of Michigan this past year with Dr. Michael McKee and Dr. Paul Chandanaboma and a few others on this study. I'll be presenting on the health information accessibility to health literacy among deaf individuals. Okay. So I wanted to acknowledge that our project was funded by the National Institute on Deafness and Other Communication Disorders, as well as the NIH, and we do not have any other conflicts of interest to disclose. So to start off, a little background. So deaf and hard of hearing individuals appear to be at high risk for inadequate health literacy compared to their hearing peers. Deaf individuals face significant barriers in accessing and understanding health information, and these barriers can put them at risk for improper healthcare usage. There's also not a lot known regarding how adequate or inadequate health literacy affects deaf individuals' navigational patterns, as well as their ability to obtain health information. So our objective of this study was to delve into what are some of the drivers of inadequate health literacy and health understanding, and what are some potential intervention sites. So the team developed a larger health literacy study, and the project was divided into 3 aims. The first aim was evaluating differences in the ASK model, or attitude, skills, and knowledge, particularly with health information. And our second aim included evaluating hearing status correlation with health literacy levels. But this study is the third aim, which analyzes navigation patterns of health information, sources of information, and methods of reliability, particularly between the deaf and hearing population. So our study recruited 26 participants, 16 deaf and 10 hearing. And since the study was occurring during the middle of COVID, it kind of resulted in an unbalanced sample. But these participants came from Flint, Michigan, Rochester, New York, and Chicago, Illinois. We adapted and validated the newest vital sign tool, which many of you are probably familiar with, to be available for American Sign Language. And this was used to determine the adequacy of health literacy within this population in aim 1 of the study. So using this tool, 26 participants were asked to return for a second visit and engage in elicitation interviews. And prior to the interviews, all the participants were given 4 clinical vignettes and multiple choice answers to make it a more active process. And we analyzed things like method of searching, navigation patterns, what websites did they use, stuff like that. Tobii eye tracking software use video footage to help us look at facial expressions of the participants as well. So in case you're interested, just some key data on our participants. As you can see, between the hearing and deaf groups, the average age was relatively similar. The females comprised more of the deaf group, and those who identified as Black and African American comprised more in the hearing group. And there were about 2 Hispanic individuals in each group. I mentioned earlier, the NVS tool helped categorize the individuals into adequate and inadequate health literacy. The Tobii technology was used by the interviewers to kind of help probe some more questions to understand what exactly are the behaviors of our participants and where are they spending time searching. And our group used Deduce software to assign codes to the transcripts and further compile our findings into themes. So I'm going to talk about some themes. I'm going to be focusing more on quotes from the deaf population that we found, because that is our population of interest. So the first theme is differences in online information search approaches. So here you can see that we found that deaf high literacy individuals tended to use their intuition when deciding how to proceed with search results. These individuals also typically checked multiple sources to verify the information. And this may be due to communication barriers, like auditory information could be a barrier for deaf individuals, whereas hearing population may find that easier to communicate with their family, friends, and healthcare providers in person. We also found that deaf low literacy individuals overall had a harder time with simple searches and navigating for health information online. The next theme is differences in information sources of support and trust in these sources. Here, a deaf low literacy individual notes the trust in healthcare providers, and that was the general consensus among this group. However, in the hearing and high literacy deaf groups, we noticed that they had some other sources that they trusted. Another theme of interest was how information was portrayed. So particularly do they prefer text or do they prefer illustrations? Again, talking about the focusing on the deaf population, but we did look at hearing population, deaf population, and among those groups, the high and low literacy. So what's interesting here is that the deaf group, particularly low literacy individuals, tended to look at pictures as a preferential source of information. And this could possibly be due to literacy barriers. The last theme is differences in recommended information dissemination approaches between deaf and hearing individuals. So I really like this first quote because it highlights some inequality in acquisition of health information, basically saying that hearing people get information first, and the deaf group feels like they're lagging on getting information, and there's some inequality there. So when asked about how can we improve that dissemination of information, the deaf group, both the low and high literacy, had a lot of suggestions, including having doctors that are just generally more engaged with the deaf community and feel comfortable with them. So I know I said a lot, but I'm just going to quickly go through the key findings and from those quotes. So deaf group members tend to prefer relying on their intuition to determine good search results. High literacy deaf groups tend to use multiple sources to verify the accuracy of information. Deaf group members indicated difficulty understanding language and navigating the textual information presented. And low literacy deaf group tended to favor pictures as a primary source of information. And this last key finding was the most interesting to me, but that deaf participants were more vocal about concerns about unequal access. So related to that key last finding, our team found that many of the interviews with deaf individuals, both from the high and low literacy groups, expressed barriers in accessibility in healthcare, as well as they just had so many suggestions for targeted approaches on how to improve accessibility. So that includes something as simple as having an interpreter during in-person visits or even virtual, captioning on virtual visits as well. And something that is important to know is many of them didn't say, okay, you need new information specifically for the deaf, but make the current information that's available online more accessible by adding more friendly language, avoiding medical jargon, and that will accommodate a lot of deaf individuals and hearing individuals of different levels of literacy. Another popular suggestion was ASL videos, American Sign Language videos, which could accommodate another subculture of the larger deaf population. So given that these deaf participants did share some specific suggestions, by implementing these, it may help reshape information accessibility, equity, and quality for this marginalized population. And one more thing that I mentioned here is the certified deaf interpreters. You may not be familiar with that. It's just another tool that could help translate the very complex medical jargon into some more simplistic language to accommodate those with varying levels of literacy. And finally, I would just like to end by thanking Dr. Michael McKee, Dr. Paul Chandanabuma, for allowing me to work with them on this project and being wonderful mentors. And I also want to thank Drs. Tiffany Panko, Peter Hauser, and Michael Pasho Arlo for letting me be part of the study. And yep, that's it. Thank you so much. I can take some questions now.
Thank you, Samantha. I was just going to take my prerogative to ask the first question when one jumped into the chat, so I'll defer. But please don't forget, put in your comments and questions into the chat. So here's a comment. A lot of helpful strategies parallel this is the point I was going to make, parallel those for low literacy individuals in general. And so my question was, in terms of written materials, are there different strategies that one would take for deaf audience or hard of hearing audiences that have limited literacy versus the general population? Is there something that we should be sensitized to when we're working with written materials that we need to address the way we think about cultural competence, and the deaf community considers themselves to have a culture? What should we be paying attention to in addition just to the obvious literacy and health literacy strategies?
Yeah, that's a very good question. So regarding when we were asking them about ways to disseminate information, something that came up was the idea of making printed materials like pamphlets and brochures more accessible. I think that accessibility looks different to every single person, but something that did stand out, especially among the deaf groups, both high and low literacy, was the idea of just more friendly language. And I had mentioned that pictures seem to be a big preference for many of these individuals, but sometimes the pamphlets have a lot of text, and it's not considered the most accessible for those with lower literacy.
So, and I just want to, terminology, sometimes when we talk about it accessible, we mean like I can find it, I can access it. And what you are referring to is sort of how approachable, that there's not this big wall of words, it will engage. Am I understanding that correctly?
Yes, there's also that facet where it could be a matter of even just where it's portrayed on the printed materials as well as on websites. So a lot of our research did look using that video software. We looked at where do individuals focus on the screen? Is it, the right side where there's search results or the left side where there's pictures? How long do they go? How many search results do they go through until they choose something that seems reliable and trustworthy to them? So that's a good point.
Right. Well, I don't see any more questions now. Feel free to type them in as they occur to you. We'll come back at the end to regroup. Thank you so much, Samantha.
Thank you.
Our third presenter is Carol Cummings. She's a professor of public health promotion education at Rhode Island College, and she's also an interim associate dean of the Feinstein School of Education of Human Development. Carol, if you will go into presenter, a slideshow mode so that we just see your slide.
Can you see that now?
It's still showing me the whole PowerPoint. So,
okay. 1 second. I just had it up on my screen.
if you want, I can show it, or you can try it again.
Yeah, why don't you go ahead and show it in the event of time?
All right, so we'll do the next slide, please, protocol.
Okay, thank you.
Let me just get this up. And now I'm going to have to swap because I have two monitors. All right, is that?
Oh, sorry about that.
No worries. Go ahead.
All right, excellent. Thank you, everyone. I will tell you this slide deck doesn't have my acknowledgements on it. So I just want to make sure that I acknowledge everyone. So first of all, my name is Carol Cummings. I'm affiliated with Rhode Island College, and my colleague, Dr. Sherry Wallington, is also here today. She also was part of the research team. And I also want to acknowledge the other two members of our research team, Dr. Molly Greeny and also Dr. Sankirth Rampa. Next slide, please. So first, let me do my acknowledgement so I don't forget. I want to thank and acknowledge the Rhode Island Executive Office of Health and Human Services, who provided the funding for this project, along with the CEOs and medical directors of the two federally qualified health centers that allowed us to come in and collect the data, the patients who also allowed us to collect data and participate in the study, along with our student data collectors who actually did the data collection in the health centers. So as you all are aware, thank you. The Healthy People 2030 objectives include 6 objectives that are focused on building health literacy skills in individuals, populations, and also the healthcare workforce. The state of Rhode Island has addressing social determinants of health as a state level initiative, along with initiative for many of the federally qualified community health centers. However, there has been limited health literacy assessments done in the state of Rhode Island. So the purpose of our project was to measure health literacy levels and its association with sociodemographic variables, along with patients' perceptions around their health, and also whether or not they felt cared for, listened to at their health center. And then in addition, what the health center could do to help them build their confidence or self-efficacy in health literacy. Next slide, please. Thank you. So the research team put together, did a comprehensive deep dive into health literacy measurement tools, and we decided that we wanted to take a comprehensive approach. Therefore, we selected 3 tools to be actually part of our study instrument. And so we use the brief health literacy screening tool, the SOL, Spanish and English, and also the all aspects of health literacy scale, in addition to demographic items and then our qualitative items. Before we pull this instrument together, we had run some focus groups at the 2 federally qualified health centers who agreed to participate in the study and around health literacy. And then we used that information to help guide the selection of the instruments to be part of the bigger tool, and then also to write our qualitative questions. We trained students who were mostly public health students and health studies students at 2 of the Rhode Island institutions that were part of the research team. And these students went out to the health centers and actually sat down with the patients who were interested in participating in the study and went through the whole instrument with them. And they pretty much did the data collection or the writing for the students. And our data collectors, many were fluent in Spanish. Eligibility included patients who were at the 2 health centers who were participating, 18 years of age or older, and they could either speak Spanish or English. Recruitment occurred before or after their appointment, as long as it was not disruptive to the reason why they were there at the health center. Our materials were provided in both English and Spanish, along with our posters. And then we provided a $20 gift card to an accessible grocery store as an incentive, along with a health literacy resource. Next slide, please. So as you can see, we had a total of 328 participants. We were aiming for almost double that, but the pandemic actually caused us to shut down our data collection in the health centers. Around 67% identified as female. In addition to that, 47% identified as white. As you can see, a little under 50% identified as having a high school degree or less. 64% rented, and 43% used Medicaid as their primary insurance. We also asked the participants or the respondents whether or not they had enough money to spend on things to keep them healthy, and about 51% said no. In addition to that, around 40% felt that their health was very good or good, and 33% reported it being fair or poor. Next slide, please. And so this is just a nice overview for you in terms of the results with regard to limited, marginal, or adequate health literacy for each of the instruments. And as you can see, one of the things that we noticed is based on the focus of the instrument, certainly the percentages were different with regard to those respondents who fell into limited and marginal or adequate. So we had 50% adequate with the brief score, we had 78% adequate with the SOL, and then we had over 65% adequate with the 3 sub-instruments of the all aspects health literacy scale. Next slide, please. With regard to significant associations, one of the things that was similar for both the brief and the SOL, we saw that race, Hispanic, Latino, Spanish origin, and education all showed significant results, where whites with the brief were more likely to be in the adequate level. Those who identified as HLS were more likely to have limited health literacy, and then also individuals who had a high school diploma or less, rented, and reported poor health status had limited health literacy levels. We found some similar results with the SOL, and then the AAHLS gave us a little bit different results, where age and education on functional, gender on the communicative score, scale. Next slide, please. We packed a lot of information into the slide deck. So one of the things that we also found was very interesting is that the all aspects health literacy scale has a question on there, whether or not the respondent had taken action to address a health issue within the last 12 months. 51% actually said no, they hadn't. And we thought that was really interesting and something that should be further explored, because when we also asked them whether or not they had, they felt that they had, were confident getting health information that they needed or getting the help that they needed to make good health decisions, we saw that the majority of the respondents felt confident or very confident. And one of the things that we want to further explore is this understanding around what it means to be a health literate person. Next slide, please. With regard to the qualitative questions, again, we saw some really positive outcomes with regard to patients feeling cared for and listened to. We also saw rooms for improvement, and the rooms for improvement, some of them did focus on bias with disability, unequal with class and race. And then also there may or there may not be somebody who actually speaks the language that's their primary language, and stigma associated with different backgrounds. There were some things, you know, certainly some basic things in terms of it would be nice to have music, maybe to have coffee, better magazines, but then also some telltale information around stigma and bias. Next slide, please. With regard to the analysis of themes that arose around measures to increase the patient's confidence, there were many strategies that came up when we did the in vivo analysis. And so one of the things, again, that we saw, and I put some examples of quotes, is that patients were interested in access to information, better communication, to be engaged more, and then also access to resource. And I thought there's some of their comments were pretty telltale. Make doctors explain better with simple words, talk more with patients, take time to actually listen to the patient. And one more slide, please. I know I'm coming to the end of my time. And so in terms of our conclusions, again, the significant associations around race, education, Hispanic, Latino, Spanish origin need to be further explored in the state of Rhode Island. And we also think that our results suggest a need to take a deeper dive into understanding who is at risk for limited health literacy in Rhode Island, definitely expand our data collection, and then also examine how individuals develop these skills and self-efficacy within their lives. And we feel that interventions utilizing this data, whether it's looking at health literacy levels at the state level or individual scores based on the instrument used, can certainly be used to inform patients as well as build their skills as well as the healthcare workforce. Next slide, please. And then questions. And then again, I want to reiterate that my acknowledgements, and I'll take any questions if I have any time left. And so will Dr. Wellington. That was fast.
That was. So I am having now a technical difficulty that I don't see my unshare button anymore. So I'd like to thank you. That's exactly what I wanted. I don't see any questions in the chat, so I'm going to take a prerogative because I've got several. I usually do. One was, I was very intrigued by the finding about 51% felt that they didn't have enough money to keep healthy. And I was wondering if you did any analyses of those people by health literacy status, and sort of delved into that as a social determinant that may relate to health literacy.
Right. So one of the things that we are addressing now, because we looked at it in terms of the levels of health literacy, we did not do that level. We did not do that next step of analysis. And that's actually on our agenda for our next step, because you're absolutely right. Yeah.
Yeah, well, we'll look forward to that. The other question that I had is a methods question, which is that you used 3 different health literacy assessment tools. And I was wondering if you could speak to why you decided you wanted to use all 3, and what conclusions have you drawn about their relative merits for the kind of analyses you're doing.
Right. So the reason why we decided to use 3 is because many of the tools are so specific. where one, the SOLVE focuses just on medical recognition. The two federally qualified health centers that were involved in the study were very interested in seeing the results of a tool that looked at medical recognition. But then in addition to that, we were also very interested in looking at literacy levels around accessing information and around self-efficacy. And so one of the conclusions at this point that we drew is that certainly you can't, for these three instruments, they look at three different contexts of health literacy. And so we really can't say that one is better than the next. We really, I think they're can be very situation specific with regard to understanding health literacy better. I don't know, Sherry, if you want to jump in here.
Oh, yes, I agree. And then some of the tools, it's important to really get at culture. And then I just want to make a point, Cindy, about your comment about looking at health literacy as a social determinant of health. Often that's an often forgotten social determinant of health. And I'm really excited to see that many health centers, hospitals, federally qualified agencies are starting to actually capture the social determinants of health in their electronic medical records. So I think that that's something very positive, and that will help us to better understand that response, about 51% saying that they didn't really have enough to live on, and how we can better navigate patients who fall into that situation.
And the other thing that I just want to jump in real quickly is that the all aspects health literacy scale, its use has been more outside of the United States. So I was intrigued by it, but the work around it really has been item specific in terms of looking at the group scores for a specific item. And that's something that we also are going to further examine.
Great. Well, it sounds like we should really stay tuned to your analyses as they progress. So thank you so much for sharing this with us.
Thank you.
Our third presenter today is in Australia, and she has elected not to wake up in the middle of the night to join us in person, but has recorded her presentation. Her name is Danielle Muscat. She's a postdoctoral research fellow at Westmead Lead of the Sydney Health Literacy Lab. So with that, I'm going to ask our folks at IHA Tech to roll the camera on her presentation.
Hello everyone, my name is Dr. Danielle Muscat. I'm from the Sydney Health
Please go
Literacy
full
Lab at the
screen.
University of Sydney, and I'm really pleased to be joining you virtually today to tell you about some work we did looking at health literacy and patient decision aids, which form part of an update of the International Patient Decision Aid Standards. Before I begin, I'd like to acknowledge the authorship team listed on the screen. For some background, patient decision aids are tools designed to help people to participate in decision-making about healthcare options, providing information on the options, such as their benefits and harms, and helping patients to clarify and communicate their personal values and preferences. There are over 500 patient decision aids that are currently available or being developed globally. The International Patient Decision Aid Standards, IPDAS collaboration, is a group of researchers, practitioners and stakeholders from around the world that was established in 2003. And the purpose is to enhance the quality and effectiveness of patient decision aids by establishing a shared evidence-informed framework with a set of criteria for improving their content, development, implementation and evaluation. As part of an update of the International Patient Decision Aid Standards, the aim of this study was to conduct a review to examine the extent to which patient decision aids are designed to meet the needs of lower health literacy and socially disadvantaged populations. To do this, we conducted a systematic review and we searched the reference list of the Cochrane reviews of randomized controlled trials of patient decision aids. So basically, there have already been 3 Cochrane reviews of patient decision aids conducted in 2014, 2017, and one this year. And so we searched the reference list of those comprehensive reviews to identify any that had assess the impact of patient decision aids on people with low health literacy or other socially disadvantaged groups. And we operationalised that by saying that studies needed to include at least 50% of participants from socially disadvantaged groups and or have conducted a subgroup analysis with those groups. And we had a deliberately broad inclusion criteria in terms of socially disadvantaged groups that was in line with the previous review conducted by Marianne Durand and team. And this included disadvantaged groups who were disadvantaged on the basis of literacy or health literacy, education, socioeconomic status, ethnicity or race, language, geographical location, numeracy, or insurance. So for the methods, we basically had title and abstract screening of 213 randomized controlled trials with a full text review of 31 of those. And then we extracted data for 25. Studies that had not been assessed for risk of bias as part of the previous Cochrane reviews were assessed using the revised Cochrane tool. To synthesize results, we conducted a narrative synthesis, and we also had a subgroup meta-analysis looking at knowledge and decisional outcomes based on whether studies had reported on strategies to reduce cognitive demand or readability in their trials. And this meta-analysis built on a companion paper with a meta-analysis of all outcomes, which I'll link you to at the end of my presentation today. In addition to looking at the randomized controlled trials and the published papers, we also searched for the actual patient decision aids that studies were reporting on. We searched online repositories of patient decision aids, and we also emailed all of the authors to request access as well. For those which we were able to access, we assessed readability using the online utility org readability calculator, averaging SMOG and Gunning-Fogg scores. We also assessed the understandability and actionability of the decision aids using the patient education materials assessment tool shown on the screen, which I'm sure many of you are aware of. So what did we find? Basically, only 25 out of the 213 randomized controlled trials of patient decision aids met the inclusion criteria for our study. So basically only 12% of studies had specifically addressed the needs of lower health literacy or other socially disadvantaged groups. Grade reading levels were calculated by study authors in 8 of 25 of the included articles. And just, I think it's important to mention, this is actually recommended in previous IPDAS guidelines. When we looked at the readability, understandability, and actionability, which was assessed by our team, no patient decision aids actually met the 6th grade reading level or below. 10 did meet the recommended threshold for understandability, as defined as greater than 70% understandability using the patient education materials assessment tool, but only 5 met the recommended threshold for actionability, and the results are shown on the screen at the moment. Studies did, however, report a number of other methods of tailoring their patient decision aids to their populations. This included the use of strategies to reduce cognitive burden, such as plain language, bullet points, visual cues and illustrations, including a glossary of key terms or narration and easy navigation. 3 of the included trials reported using the edutainment decision aid model, which basically combines tailored soap opera scenes with interactive learning modules as part of the patient decision aid. In addition to kind of methods of tailoring, a number of studies actually reported on the involvement of experts or consumers in the development process. So 9 studies involved a communication or literacy expert, and 16 studies reported involving consumers in some way. A minority of these included a patient partner on the research team, and the vast majority included the involvement of patients or consumers in the decision aid in another kind of method. 12 studies reported conducting focus groups or interviews with patients, and 13 studies reported conducting pilot testing, user or usability testing with target groups. Our meta-analysis found that patient decision aids led to greater knowledge improvements in studies that did report using strategies to reduce cognitive demand as compared to studies that did not. And the results of that are shown on the screen. However, we did not see any significant differences for our decisional conflict outcome, and there were no significant differences for either outcome based on whether studies had reported calculating a grade reading level for their decision aid. So as with all studies, there are strengths and limitations of this work. In terms of assessing readability, we followed best practice guidelines as recommended by Health Literacy Connections, and that included preparing the text by removing headings, sentence fragments, bullet points, etc., and averaging gunning, fog, and smog indexes to obtain our readability score. However, it's important to note that there were discrepancies between the readability statistics reported in studies and those which were calculated by our team using this method. And it's likely this is on account of the variations in terms of text preparation, the readability formula used, and the method of conducting the analysis, such as whether studies had used an online tool or calculated the formula manually, for example. However, often these details just weren't reported in the decision aid trials. We acknowledge that the PMAT is a subjective tool, but we did ensure that it was all patient decision aids were dual coded using the PMAT by trained assessors. Other limitations include the fact that we were unable to access 13 of the 24 patient decision aids, and we did not include alternative formats for decision support such as option grids. And we also excluded studies with older adults that did not report any other measures of disadvantage. However, we did have a deliberately inclusive inclusion criteria. We used the new version of the Cochrane risk of bias tool and ensured that screening, risk of bias assessments and data extraction were all conducted by 2 independent reviewers. So what can we conclude from this work? Basically, a diverse range of strategies have been used to tailor patient decision aids to socially disadvantaged populations. And preliminary evidence from our meta-analysis suggests that knowledge improvements can be seen when strategies are used to reduce cognitive demand. However, work is still needed, particularly in terms of transparent reporting of patient decision aid development processes, including details related to how readability assessments were conducted and how target populations were engaged. Greater consistency in readability formulas will be useful for the field as a whole, and it's really important to move towards a paradigm where we include patients as equal partners in the decision aid development process. So the findings of this work have recently been published in Medical Decision Making, and it can be accessed using the QR code on the screen. And there was a companion paper which had a broader meta-analysis of all outcomes, was also published concurrently. But for now, thank you so much for your time.
Well, unfortunately, we are unable to ask Danny any questions, but I love seeing presentations on shared decision-making at this conference. We are currently having a conversation at HARC about the nexus of shared decision-making and health literacy, viewing them as overlapping Venn diagrams, but that health literacy is definitely a prerequisite to shared decision-making. So we only have a couple of minutes left. And so I'm going to ask the one unanswered question that's already been entered in the chat. And this one was a methods question for Jessica. So Jessica, if you could turn on your video. We had the question, is the distiller tool like the Covidence tool for scoping reviews? And that just flew right over my head. So you can tell us a little bit more about that.
So
Thank you for coming on to who's the one who asked that question.
Right, I'm not familiar with the other tool that you name, so I can't be too helpful there. But I do know Distiller can be used, for a systematic review or scoping review. It has a lot of features that you can kind of customize the tool to suit your own needs. So it's very adaptable. I do know it requires a good amount of training. I am not trained on using Distiller, but members of my team were. So it is a tool that, it takes a little investment to get to know, but once you know it, it's apparently just a very nice tool to have. So,
like so many of our technology tools.
Exactly.
Gary, we got 1 minute. So did you just want to jump in very quickly?
Oh, I was just going to say thank you, Jessica, because we teach our students to use Confidence. A lot of librarians work with that too, and the distiller too sounds a lot similar. I'll have to look at that and training our students as well. Thank you.
Fantastic. Yeah. Welcome.
Great. So we are at the close of our hour. I want to thank all of our fabulous presenters. Really terrific and interesting work. Thank you so much for sharing it with us. We have now a 10-minute break before our next sessions. And the next sessions are so important, networking sessions to try and get some of that contact that we are sorely missing and sorely in need of. I understand, Michael, that there was a bit of confusion in terms of the links. Did you want to comment on that?
I hope it's been sorted out, but there are 3 different networking sessions now that after the 10-minute break. If you're not in the room that you want to be in, you can go out and go into
the other links.
but effectively, and you can even do that without having to, put your shoes on, if that's how you roll in COVID times. Effectively, there's a networking session oriented towards research with and practice in pediatrics and younger adults, hosted by Dr. Yin, by Shana Yin and a colleague. There's a networking session oriented more towards research and practice for older adults, hosted by Dr. Wolf, and also one that I'm going to host oriented towards measurement. So hopefully those are appealing. But thank you very much to the speakers, the presenters in this session. Fantastic to hear about your work, and good luck, and a little break, and we'll see you back after that. Please be sure, if you might, also to vote for the posters. That'd be great.
Thank you. Bye-bye.